All right, well, I think we have everybody in, so we'll go ahead and get started. Good afternoon. Welcome to IPHA's third Thursday Lunch and Learn web series. My name is Brett Norris. I'm the communications coordinator for IPHA. I'm glad that you could join us today as we wrap up our 2022-23 season of IPHA Lunch and Learns. It's been a great season so far, and today should be no different. The session is being recorded and it'll be posted to IPHA's YouTube channel later this month. Before we get started, just a couple housekeeping items. Your microphone should be muted during the presentation, just to make sure we can hear the presenter and help us keep some bandwidth. You can put your questions in the chat or Q&A features here on Zoom. There'll be plenty of time for a live discussion at the end. You can take yourself off mute, turn your camera on, or keep throwing questions in the chat, whatever you're comfortable with. Today, we're joined by Tinika Roland, who will speak with us about heart health education and advocacy. Again, there'll be plenty of time for discussion and Q&A, but for now, I'll just hand it over to Tinika to get us started.
Good afternoon, and thank you for joining today. So what we're going to do is really just talk about, hearts in the community. That's how I'm going to phrase it. Hearts in our communities. And so everyone has a heart. So that's part of my tagline is everyone has a heart, and I'm going to encourage you to take care of yours. Heart failure is a leading cause of death in America, and cardiovascular inherited diseases is the leading cause of sudden death in young people, y'all. And so I can only imagine that you want to spend a little bit more time with children and your loved ones. And I even can suspect that you want to spend a little bit more time making sure that your heart continues to beat, right? So you can really experience the joys and the precious moments with your friends along with your family. And heart failure many times can be prevented. And it may be, not always, it may be preventative, and there's also maybe treatable. So what I want people to understand and know that many times we aren't aware that cardiovascular genetic screening is available to people, to patients at a low cost or no cost. And I think many people aren't aware that it may be a low cost to our patients. And when you are able to help identify at-risk patients and family members, it is often life-saving. And so once again, I am Tinika Roland. I am a health equity consultant. I am also a heart patient, and I am the proud mother of a heart transplant patient. One other thing I want to share with you is I am a fellow through Mid-Iowa Health Foundation, and my fellowship is sponsored by Iowa Public Health Association. So let me bring up my presentation here as soon as I figure out how to do that. Where's my presentation here? Okay, there we go. Let me get that here to share. All right. So one thing that a few things we're going to cover, and then I'm going to also bring in a guest and more of a practitioner clinician to provide a little bit more insight. So again, everyone has a heart. Want to advocate for that. Want to advocate for the cardiovascular and genetic and clinical screening. And so we'll talk a little bit about 3 A's for heart health. I share a little bit about my story, and then we'll have talk a little bit about cardiovascular genetic evaluation. And then throughout this presentation, I'm going to talk a little bit about some things that you can do to help. Once again, we really want to talk about education and educate more individuals within our communities. So let's just do a brief definition of heart failure. And so this is just, we're going to do a high-level overview today. So heart failure, it occurs when the heart muscle doesn't pump blood as well as it should. That means some parts of the body does not get enough blood. So we know that the heart should contract. And when it's contracting, it's actually delivering the blood to our vital organs and to the rest of our body. When it's not contracting the way it should, and maybe it's struggling, then many times that's considered heart failure because our bodies are not getting the oxygen and the blood that it actually needs. Now, according to the Center for Disease Control and Prevention, this is directly from their website, they actually indicated that 877,000 are impacted by heart disease, heart failure, stroke, and other cardiovascular diseases. And we know that heart disease is the #1 cause of death in America, and then stroke is a 5th leading cause of death in the United States, I should say. So when you look here, we're talking about 1 in 3. These statistics are alarming. 859,000 people each year dying of cardiovascular diseases. And then let's look at how it impacts our healthcare systems. $216 billion. That's a cost. Now, it could be more, it could be a little less, but this is what our the CDC, the Center for Disease Control, is saying. And then think about those that are dying early or of sudden death. 147 billion. That's impacting the loss of productivity from sudden death. That's alarming. So that's why we need to start paying attention, and we need to start educating and advocating in our communities. So look at this, just take a moment and look at these headlines. Look at some of these headlines, and then, think about what these headlines might mean to you or might mean to people throughout our communities. So how many times have we seen in the news that an athlete, they were running for that touchdown, right? And they were trying to get to that touchdown, or maybe they went in for that layup on the basketball court, or they were running track and they were running on the track field, and then they were just trying to get to that finish line, and then sudden death. So you see here, we have some high school students, we have some young people. We talk about, athletes suddenly collapse. And then 80% of athletes who die suddenly, they don't have no symptoms. They don't have any symptoms. And then it's not even showing that there is any family history of heart disease. That's alarming if there aren't any symptoms and there isn't any history, but they suddenly die. But in order for them to be able to participate in those athletics or in that sport, they had to have a physical, right? They had to have a physician approve that and sign off on them to be able to participate. So what are we missing? What is missing in those annual physicals that's being signed off on? And then we have Ashara Hughes. And then we know in January, just across the nation, when Damar Hamlin collapsed, then that became, there was more attention to heart health and having the AEDs and people being trained for CPR. So many organizations were retraining, or additional organizations were expanding their training and making sure that people were aware. But we want to, we really want to do more. We want to make sure that we are able to reduce the sudden death of our young people. We want to be able to improve the health outcomes. We know in public health, prevention is one of the key factors. We want to prevent, but we also understand that we may not always be able to prevent all chronic diseases or all sudden deaths, but whatever we can do to reduce and improve the health outcomes, I think that is essential and important. So let's just talk about some 3 common inherited heart diseases. So these are the most common inherited heart disease. And so familial, basically what we're saying with that is that there's some form of a family history. So keep in mind, I'm a heart patient. I am not a clinician, but based on my research and working with my team, they're helping educate me and helping me so I can inform other individuals within the community. Now, when we talk about inherited heart diseases, please remember and please note that the presence of a mutation does not always lead to heart failure. So I want people to be aware. Some people may actually have a mutated gene, but it doesn't necessarily lead to heart failure. When we're talking about familiar hypertrophic cardiomyopathy, that is pretty much more of the thickening of the heart muscle. And when we have the thickening of the heart muscle, that can lead to heart attacks and that can lead to strokes. When we're talking about familial dilated cardiomyopathy, that is almost the opposite. That's like the thinning and the weakening of the heart muscle. And there are times where people that have dilated cardiomyopathy, they do not present symptoms. And when it's untreated, or, when people don't even have those symptoms, that can cause major problems. That actually could lead to heart failure. So we got to really pay attention to what's happening in our bodies if we have those signs in those symptoms. And then the last one is familiar hypercholesterolemia, and that's essentially when the causes the heart muscle. That's really when we're talking about dealing with cholesterol, and that can lead to heart attacks and strokes as well. So here is another headline. So many times when we're talking about awareness, we're talking about advocacy, sometimes it takes those influencers. It takes people like you. It takes the leaders within the community, the people that have those connections to be able to help bring more awareness. And nationally, it may take a celebrity. It may take the Damar Hamlin. It may take the Kareem Abdul-Jabbar. So recently, earlier this year, Kareem talked about his experience and being diagnosed with AFib, and now he's partnered up with No Time to Wait. But he had symptoms, but he didn't pay attention to those symptoms of what he described in his story. It wasn't until he almost passed out when he was walking with his son, which sent him to the doctor, that was like the biggest sign. Like, hey, I got to go do something. And so he was really surprised because he's like, hey, I've been athletic, I eat well. How the heck am I diagnosed with AFib? So once again, those individuals that may be considered healthy, they also may, experience heart failure. So please, please, please just consider being an advocate, consider educating and helping more people become aware of the genetic and cardiovascular screening that is available to many individuals. So here is another headline that I wanted to share. This is more recent. This was announced, I believe, on CNN in October of last year. However, this was a study that was from 2015 through 2016. So there were about 377 individuals, I believe, that was a part of the study, and 27% of them identified as Black. And it says here that, Black heart failure patients are less likely to get devices and transplants that they need. And so that's really critical. So now we know that we always known that disparities existed. But when you have a study that provides the statistics and the data, then it's like, okay, what are we going to do? What are we going to do about that? In public health, we always talk about, equity. We want to make sure that everyone has what they need in order for them to survive and thrive. And so many of these doctors in the study, they talked about, some of it wasn't surprising, but some of the information was surprising. Now, the numbers that they're showing in this particular study, they're saying that Black patients, 11% of the Black patients received either a device or heart transplant compared to 22% of white patients. However, the death rates were pretty much similar, 18% for Blacks and 13% for whites. So one thing we want to continue doing is looking at the social equity. We want to continue making steps. So all, we want to make sure that we have quality healthcare for all across our nation. And then another news line is a genetic mutation that is associated, and this particular one is associated with Blacks. They may have an increased risk of heart failure. And with this particular one, it's individuals that have West African ancestry. So 4% of individuals with West African ancestry are at a higher risk of this particular genetic mutation. And so this is something that I just recently learned working with a genetic counselor. And so this is really alarming information when we talk about 4% of a particular ancestry. So this is one reason why we want to make sure that we continue to educate. And with this particular one, there is now a medication that is available, and then there is an organization that is providing genetic and clinical screening for free for those that are at higher risk of, and this one is an amyloid cardiomyopathy. And so cardiomyopathy is one of the most common inherited heart diseases, and the hypertrophic one, that one is the most common one. So let's talk a little bit. I wanted to share a little bit of my story and give you a little bit of background. And one of the reasons why this is really important to me, because we know that African Americans or Blacks are twice as likely to die of heart disease or heart failure than whites. And so the more that we know, the more aware that we are, the more that we can begin to advocate and we can begin to share and educate. So I want to put faces to my story, right? Sometimes when you tell your story, you don't have that face. When you have that face, you can develop a better connection. So I'm in Des Moines, Iowa. So I don't know where everyone else is, but I'm in Des Moines, Iowa. So you see here, my father is still living. He is in Florida, in Kissimmee, Florida. Now he is presumed to carry this mutation. So everyone carries what we call the FNLC gene. That's a gene that all of us humans have. Now we know that, with our genetic makeup, we have our cells, and within our cells, we have our DNA and our genes. And there is a code, there's a genetic code. And with that code, it's like written, in writing. With us, there's a misspelling in our genetic code. So I'm learning all this information more recently. And so we presume that my father has it. My father has not, he has not gone under or has not had the genetic screening and the clinical screening. Next to him is my eldest brother. He had the genetic screening last year. And then I had the genetic screening in 2017. So I know that I am a carrier of a genetic mutation of the FNLC gene. And so because I had this information, because I was aware, I was able to make an informed decision. It took me a while to make this decision. It took me like 6 months. But I decided to implant an ICD. So an implantable defibrillator is what I have. So we know, many of you are aware, clear, boom. I have that internally. So I have what is called a transvenous one in my chest. And so with that machine, and I'm gonna call it a machine because that's really what it is, I have a top lead in the top of my heart, which is basically a wire in the top chamber of my heart in my atrial area. And then I have another one that's in the bottom chamber of my heart, which is in my ventricle. And so it's able to monitor how my heart is contracting. And then if I have irregular heartbeats or if I have fast rhythms, then there's a pacing function, which I usually don't use, but if I need it, it will kick in. And so it'll try to pace my heart out of a regular rhythm. And if it's unable to do that, then it'll shock my heart. In 2022, last year, I was shocked 6 times in one day. And so so I've been shocked 7 times total, but I was shocked 6 times in one day. And so that was almost like PTSD. But the good thing is I had it. I had it because it was able to help prevent me from sudden death. And then next to me is my niece. So she is a nurse at Mercy and also at Broadlines. She is the daughter of my eldest brother. So she took time to find out last year that she is also a carrier of this gene. So she's able to educate while she's, working in her field. So let's go back a little bit. My father had 2 twin brothers. In 1979, they died suddenly 3 months apart. So back in 1979, we're not thinking about this. We don't know. We don't have it. We're just, heart failure. We know that many Black people have, hypertension. They die of heart disease. So we're thinking it's that. But then we've learned that we've had other family members that have died suddenly, just dropped dead. So we presume that they carry the gene as well. My father was able to get my uncle's records from the local hospital here and the hospital in Iowa City, and was able to see in those records cardiomyopathy within those records. Each of those, my twin uncles, they actually had one son each. So one is still living. He, about a month after I got my ICD, he got an ICD as well because he found out he is a carrier. And then my other cousin who is deceased, he had a pacemaker implanted, and his mother told me that he had dilated cardiomyopathy. So we presume that he also is a carrier. So this information, the genetic screening and clinical screening actually helped my family become aware. We had no clue. Now, this is my son. In 2017, my son was 21 years old and he was struggling breathing while he was working. And so he went to the hospital, to the emergency room, and then they did different labs and checked the cardiac enzyme and found out that he was in heart failure. And so in April of 2017, he received a subcutaneous ICD underneath his left arm. By May, he had a stroke. By June, they implanted a balloon pump. And by June, he received a heart pump, which is the LVAD, a left ventricle assist device. And so you can see his x-ray here, and you can see the LVAD that was in his body. And then the next picture here, you can see where he embraces his LVAD. And you can see the wires that were coming out of his abdomen, and then it's attached to 2 batteries that he would keep in his pocket, which actually operated and gave power to the heart pump inside of his chest. And then December of last year, December 21st of last year, my son received his heart transplant. So he has a new heart. And this is KCCI ran a story on him last year because it was right before Christmas. And so is a Christmas blessing. So for over 5 years, he lived with an LVAD. And so he is 27 years old now. So I share that to say that this is one of the reasons why it is important to me to share this information, because if we did not know about the clinical screening and genetic screening, it's possibly saving many of our lives. 2 of us have implants. Another one, it is recommended for them to get the ICD. It's a hard decision to make. So I respect the fact that this other family member is trying to decide what they want to do, if this is something for them. But it can help, it can help prevent sudden death, but there's also methods to treat. So let's get some A's for our health, right? So the awareness is first, the advocacy is second, and then action. So that's where you come in. That's where all of you come in. So we want to make sure that we're talking about the awareness. We're going to talk about, what do you need to do? What can you do? We also want to be aware that viruses and bacteria can impact our heart health. And the more research that they're doing now is finding out that COVID-19 has an adverse impact on our heart health. I contracted COVID in 2021, and after I contracted COVID, I started feeling irregular heartbeats. I had not felt irregular heartbeats before then. So I don't know. Of course, I'm not a clinician. I don't know if it like flipped that, that gene on and made it start being active or not. But I want to make sure that people are aware that it can impact our heart. So be aware of your own health. Make sure that you're talking to your healthcare team. And if you need to advocate and go with someone to talk to them about their heart health, please, please, please make sure that you're asking the appropriate questions for whoever you're working with. Some people don't know how to speak up for themselves. Some people are silent. They don't even know what questions to ask. I go with family members that when they get that bad news, their brain just shuts down and they don't know how to ask the questions, or they don't even know what the next steps are. So please, make sure that first you're aware, then we start advocating for people. This right here is my niece, that's the nurse. So I designed this awareness shirt. So, again, the campaign, everyone has a heart, take care of yours. So we just want to make more awareness of that there's genetic screening. So this is just a way of making more people aware. And then the advocacy. We know that the physical exams, we have to have the physical exams. Don't miss your annual physical exam. Make sure you're getting that taken care of. We know that when we go to a physical exam, they're checking our vitals, our respiratory, they may do abdominal checks and that type of thing. But sometimes our physicians are missing some stuff. I mean, we saw those headlines, right? Some of those young people, they weren't aware that they had any type of heart condition. So start advocating if you feel that you need, or if someone feels that they need an additional exam, additional testing, please, please, please ask for it, advocate for that. If you think that you need EKGs and echocardiograms, many insurance companies do pay for that. The average cost of an echo in the state of Iowa is $44, but the cost can be between $99 and $145. The EKGs, when we're checking the electricity of the heart, they can range from $1,000 to $3,000. But many insurance companies do pay maybe up to 50%. So if you need those type of testing, that's what's going to actually look at the imaging of your heart and determine the electricity of your heart. Sometimes we need that. And I like to advocate that they start implementing those in your physical exam, so they're not missing any heart conditions that some of us may have. It may cost a little bit of money or a lot of money. And so we know that the pharmaceutical companies have a lot of power over how much our medicines, cost, but medicines can help treat. They can help treat heart failure and heart diseases, but many of us, we need that money. So maybe if you're a lobbyist, or if your organization has that, maybe you can start advocating for that and lobbying for not only lower costs and for prescriptions, but options. This is just, if you need additional exams, then just request those additional exams. This is my son when he was getting his EKG, when he was in the hospital, and his echo. This was after his heart transplant. And so then take action. So I'm going to get ready to finish up. We got to take action. It's time for action. We know there's prevention. Public health is one of the things for us is prevention, but then we may have to intervene if we, in the event that the progression has started. We know that, when it's situations of inherited conditions, intervention may be the first best step, but our goal is to manage those symptoms, prevent the conditions from worsening, and protect the person from any life-threatening situations. So one thing that I may want to start including is maybe having a toolbox for primary health care doctors, making sure that they're asking about family history. But I also want to encourage you to ask about your family history, and not only your immediate family, but take it down some of those leaves on your family tree and ask about the great-grandfather, the great-grandmother. Did anyone have heart disease? Was there any sudden death? Anything like that. Encourage you and encourage others in the community to use, heart health risk assessments. University of Iowa has a free one, Mercy One has a free one, and then maybe your primary care doctor can make those referral to the heart doctors, cardiovascular doctors, as well as the genetic and the genetic counselors, because those are the ones that are going to help you understand what the process is for the genetic and clinical screening, and then help you explain your results. And so I developed this poster. So I'm going to encourage you to ask your local clinics, ask your community centers if they would be open to posting this poster. So this is asking, why is cardiovascular genetic screening important? It asks some questions about your own family history or your own history, and then the benefits of genetic and clinical screening, and then it gives you the average cost and out-of-pocket cost. So this is a poster that is available Iowa Public Health Association has this poster and has access to this poster. We'll be sharing this information at Juneteenth this weekend as well. Again, Mercy One and as well as University of Iowa has the free heart health assessments that's available on their websites. And I want to make sure that Katie is in. I can't see everyone. Oh, yep, I see
I'm
her.
here,
Okay, perfect, perfect. So I want to encourage you to be informed, be an advocate, and survive. So, and these are just some resources that I use, and those can be available to you. But I'm going to turn it over. Now, she is my nurse. She is my champion. She has taken time out of her day to share because she's been educating me. So I'm going to turn it over to you, Katie. Thank you so much for joining and helping me.
Oh, you're so sweet, Tinika. And I really, thank you for inviting me to talk, but also can't speak enough of how great it is that you're advocating for those in your community and to get the word out there. This is really where the work's done. I tell people we see, the needles in the haystack in the genetics world, but it's finding those needles. That's the art of it, and knowing where to look and how to look. So I'm going to talk briefly here, and again, kind of like Tinika said too, kind of an overview of when to seek cardiovascular genetics evaluation and what some red flags could be. And I want to start by, cardiovascular disease in general is very complex, involves a lot of genetic and environmental factors. So we're going to hone in on the genetic role that I circled here, but a lot of other factors, age, and a lot of modifiable risk factors too, like the blood pressure, the diabetes, how much exercise, smoking, social, cultural factors, even more that's not even included on the slide that play into our heart health. So we're one piece of it, but really want to focus on the genetics. And I'm not going to get too in depth here, just take you maybe back to some brief, high school biology. And then just a reminder, so in each of our cells, we have DNA. And this is kind of what I tell patients, the instruction manual for how to make a body. And if part of that manual is written wrong, then whatever protein is supposed to be made is made wrong. And that can have this kind of system effect on whatever organ it is that's part of. And then also recall that you get one copy of genes from mom and one copy of genes from dad. In some genetic conditions, you need a bad copy of both. Most commonly in heart disease, a lot of the genetic heart conditions that we see, you only need one bad copy. And that's why a lot of times if there's a genetic heart disease, first degree relatives, so this would include kids, siblings, parents, a lot of people like Tinika talked about in her family, have this kind of 50-50 chance of also inheriting this bad copy of the gene and developing the genetic heart condition as well. And when we think about genetic risk that we evaluate for, there's two types that I kind of like to think about. One, like in Tinika's family, is a single gene disorder. So this is where there's a single abnormality in the code. So here is where, where you should have the nucleotide, with cytosine, instead you have thymine. So it's one single, all it took was one thing being off, and then you get this manifestation. Whereas, it's one gene that's a problem. And this is where genetics really comes into screening in the forefront. And the other and more common too, what we can see is we call multifactorial. So this is where you don't just have one or several genes playing into it or making you more susceptible to heart disease, but also then the environment. So that's the blood pressure, the diabetes, the smoking, that kind of thing. And then you get this kind of overlap. And so it's good to think about both, genetics in either setting. But then, what are these, we call them the red flags. What are the things that we should alert you to be talking to healthcare providers about your genetic risk for cardiovascular disease? The first clue, maybe the most obvious, is if you have a known or suspected genetic condition. In this case, like in Tinika's, we know that she has this familial cardiomyopathy, is the FLNC variant. We know it's there. We want families talking and sharing this so that we can look into that. The second being multiple family members affected with the same or related condition, especially if they're young. So for example, you hear like Tinika said too, with the athletes, like these people who just shouldn't have heart disease and with heart failure, like that's suspicious. And so that's where, again, you're healthy, exercising, not on meds, not diabetic, not smoking, and they're just young with these conditions. And then unfortunately, the sudden death or dying young or unexpectedly. And we don't just say kind of other kind of factors too, is we think of even single motor vehicle accidents, drowning in a good swimmer, so there's those really tragic things that just can't be explained. And we'll a lot of times try to coordinate postmortem testing in that family member too. And so that those living can have some, some guidance. I'm not going to, Tinika hit on the three most common that we see. I was just going to kind of throw some names out there that you may or may not hear. And so from a genetic clinic, we take care of patients with primary cardiomyopathy, which is the heart muscle. So this would be like the dilated cardiomyopathies, arrhythmogenic cardiomyopathies, the hypertrophic, and non-compacted. So this is heart muscle. And then sometimes it's even a genetic condition that affects the whole body. So not just the heart, but the heart's involved in how that disease presents. This can be amyloidosis, Fabry, muscular dystrophies, mitochondrial myopathies. Again, just kind of throwing some names out there that you might hear, oh, my Uncle Bob has that. That's a red flag. And then familial hyperlipidemia, which can be high cholesterol that's running in families, but how that often is presenting is young heart attack and stroke, usually less than 50, sometimes even 30s, very, very young. And then we also see aortopathy. So this would be like your aortic aneurysms and dissections, or you hear of more systemic connective tissue disorders, Marfan, Loeys Dietz, EDS. Again, not that we need to go into detail about these syndromes, but just those are the ones that you hear about. And then similarly, arrhythmias. So Brugada, CPVT, long and short QTs, and cardiac death. So we, under this, I should say too, in the cardiovascular genetics clinic, there's two cardiogeneticists, myself as a nurse practitioner and advanced genetic nurse clinician, and then two genetic counselors. We see this kind of slew of different types of inherited heart disease. And so now, coming back to, if this is it again, when are things, what steps do I take? And so I kind of have a few steps kind of laid out. And the first, and arguably, the most important is just talking with family, knowing, what their health is like. It's not something that's talked about often, and it's not fun to talk about often, but you don't know unless you know. And so taking the time to talk with families. Is there anything in your heart health, or is there anything in your history that I should know about being your relative? We're sharing genes. We need to share that information. And so, again, these are talking to family members about red flags. And when you go to talk to, your primary doctors or cardiologists or genetic, if you're meeting with a genetic counselor, the more details you can get, the better. And so again, this is kind of reiterating those red flags where people who have heart disease, especially before 60, and get those details. What kind of heart disease was it? Did you get a stent? Is it a valve? Is it a aneurysm? Is it your muscle? Trying to kind of tease out those details and writing them down. Are there people in your family who have risk factors for heart disease? Diabetes tends to be a very strong genetic component, and who in the family has diabetes, or who has this high cholesterol, and knowing, who has the risk factors, and gosh, they have high blood pressure, they're so in shape. Again, those kind of weird, well, that's odd, and it might make you think genetic, and hey, you share those genes, so you should also be getting those checked too. Abnormal heart rhythms, again, the details, is it the top, is it the bottom, what kind of heart rhythm, if you can put a label to it. Those dying young deaths, dying unexpectedly, being a red flag and very sad, and needing pacemakers or defibrillators. They're very similar. A defibrillator has more juice, so knowing if someone has a pacemaker or a defibrillator is helpful. And then, of course, if there's any known variant or known abnormal genetic test, definitely something to communicate and talk with your family about. And so then you take this information you got from your family and you bring it to your primary care provider. And this is where they can help you, work with you to tease out, is this something that's multifactorial and we're going to work on a lot of risk factor modification, or hey, yeah, you do have a lot of diabetes in your family. Typically screening wouldn't start until this age. We're going to go ahead and screen you now. So it's a comprehensive and a really good thing for your family to know about your family history, or your PCP to know about your family history, so they can tailor their treatment to you. But then also helping identify those red flags that they should know about, or that we try to teach in schools, but then also in presentations like this, where that we need a genetics evaluation. This is seeming beyond risk factors. This seems like there's something going on genetically, and we should find out more. And for some people, this will lead to the step 3, and that's your formal genetics evaluation. Maybe with a combination, kind of like I said, we are very multifactorial at our clinic at the University of Iowa over here. We have genetic counselors, cardiologists, and then myself as an advanced practice provider, all working to put the picture, the puzzle together, and then treat you, and really treat families, and making sure they're getting the appropriate treatment for whatever genetic condition we discover. And so what you would do at a genetic evaluation, or what to expect, is we make a pedigree, which I have a picture here, and take a very detailed family history. So come in with those notes. Your homework beforehand is to be talking to family, but we often have people texting each other during these, trying to get details, trying to decide if and what type of genetic test we're going to do. And then we collect blood, typically in clinic. It's a blood draw, and that's where we send it off, and that's where they get your DNA from. They do an investigation of benefits to see what it would cost. A lot of the cardiac test panels that we order are free or covered by genetic insurance, so it'd just be like your copay for the appointment. But they always do a benefits investigation, and won't, it used to be genetic testing was thousands of dollars or hundreds of dollars, and just wasn't reasonable. The most people pay out of pocket is $250. But like I said, for most of these tests, they're free for cardiac. I can't speak to cancer and all those other ones, but cardiac wise gets good sponsored testing. And then we discuss the risk and benefits of, if we find a gene, what that implies for family. And typically we get those results back in about 2 to 6 weeks. And then step 4, and this is coming back full circle of talking to the family about the results. And so, did you, if we found a gene that's abnormal, then that's where we recommend cascade screening. So getting all those relatives in to see who's at risk. And if it's negative, often we don't rule out genetic contribution. It's just the science isn't there to know what gene is causing it, or which genes. And so that's when we talk about what kind of screening to do. And that's on the next slide here. But we give this all in a Dear Family letter too. So really the role of the patient just has to be like, here's the letter, so that you don't have to be the middleman to all of this. And then we hit this last step here of the family screening. So like I said, if we find which gene is causing it, we can offer to screen other family members for the abnormal gene. Otherwise, we do what's called clinical screening. And that depends on what diagnosis we're working with. A lot of times, ECG, echo, maybe the different types of MRIs or stress tests or that kind of thing. Again, depending on what the diagnosis is. Adults, usually we clinically screen every 3 to 5 years. Kids, depending on the diagnosis, but once they're active, can sit still for this testing. We do annually, just because they change so fast, and a lot of times they're so they're in sports and doing all this kind of stuff, and so we're pretty involved with their screening with that. So again, it all just kind of depends, looking from a bigger overview. So again, thank you, Tinika, for being such an advocate in our world, and really trying to push the education, and you don't know till you know kind of thing, and you want to know before you have to know. And then as you you've done a great job presenting. It's so scary sometimes.
Yeah, thank you so much. Yeah, sometimes you don't want to know. This is not a club that you choose to join. However, but if I can help educate more people to help their family members, then definitely. So thank you. Are there any questions as we get ready to close out?
I, of course, have questions, and they have to do with the cost of any of this. So I work with, my name is Lata De Mello. I'm an advocate at Monsoon. We serve victims of domestic violence, sexual assault, human trafficking in the Asian and Pacific Islander communities in Iowa. I know some of you here and this at this event, but Tinika, and this is also for Katie. So I work with a lot of community members who cannot afford healthcare or have Medicaid that may or may not cover all these tests. I'm not sure. Do you have any idea of how that can be addressed?
Yeah, I will say Medicaid actually covers very well. I have more problems with Medicare. Sometimes they want you to, it depends. We try to do as much testing if we know what they're coming in with beforehand, but sometimes they want you to see the patient and then do the testing. But for the most part, I don't know that Medicaid patients pay much of anything. And then, you know, you would have like your co-pays for like a clinic, like a specialty visit. But yeah, I don't want to, kind of a blanket statement, but we have really
no,
good
just your
medical
experience.
Yeah.
Not that you should know all that, but just want to know. I should have clarified.
Yeah, sometimes they make, instead of just, they won't let you do all the tests at once, they make you stepwise it. So there's that kind of factor. One of the HCMA, one of the HCM associations, they do, I think it's $600 a year. They offer travel grants as well, because we run into that too, of the expense of getting to Iowa City.
Right.
So if it's HCM, they have the travel grant you can apply for.
What is HCM?
HCM, hypertrophic cardiomyopathy.
Oh, okay.
That's the thick part.
Okay.
Yeah, the other ones we don't have the grants for travel, but the testing gets pretty well covered. And genetic testing, the panels we do for the cardiomyopathies, they're free. Currently, they're sponsored.
Okay. Thank you. That's all I wanted to know, because that's the first thing. People neglect their health because they can't afford it, and this country is not really supportive of universal health care. So that discrepancy already. And forget race and class, all of it is bundled into one when it comes to healthcare. So absolutely. We have to be creative all the time, looking for ways navigating through these loopholes, through loopholes, right?
Absolutely.
What other questions do you have? Thank you for your question.
Thank you, Tinika. You're welcome.
Comments?
I do want to add, it's so lovely to see your son and the whole event finally that led to the Christmas blessings, as you called it. But how is he doing now?
He is doing well. He finished his cardiac rehab last month. He is back in the swimming pool now, and he is back working out at the gym. So,
okay, great.
Almost 6 months. It's almost 6 months post-heart transplant.
So does he have to have any kind of immunosuppressants? Does he have to have, is this lifelong, and will he?
Yes.
Okay, so yes to those.
Yes, we're both.
And how often is his checkups,
I think he has labs every other week, and then I believe he goes monthly back up to Iowa City. And I think sometimes he has a nurse that comes into his home to do his blood draws.
Okay.
So thank you for asking.
You're welcome. And I'm based in Iowa City. We have office in Des Moines, Iowa City, and Dubuque. So if he comes here, and if you need anything, let me know. If he needs anything, let me know.
Thank you. Appreciate that. Well, thank you, everyone. Thank you for taking time to hear my story and to learn more about genetic and clinical cardiovascular genetic and clinical screening. I just think it's so important for people to learn more. I didn't know about it. If it wasn't for my son's heart condition, I would not have known that I was a carrier I think I was 47 years old at the time. And so, this brought light to our family, and so this might help other families as well. So thank you for taking time to listen, and thank you, Katie.
Oh, like I said, you're putting in all the work. I'm happy to be part of it.
Appreciate it. And that's all that we have.
All right, well, thank you very much, both of you. Thank you, Tinika, for sharing your family's heart health story. I'm so glad that your son is doing well after his transplant. Thank you, Katie, for sharing your expertise with us. And thanks to all of you who came and shared your lunchtime with us today. This was our last Lunch and Learn of the 2022-23 season. We'll just have a couple months off, but we'll be right back with the 23-24 season in September. So we hope you can join us then. Keep an eye out for the schedule and the registration link for that. We're always looking for potential topics for future Lunch and Learns. We have a few openings later in the next season. So if you're interested in sharing your work, or if you know others who might be interested, reach out to me. My email is Brett, B-R-E-T-T, @iowapha.org, and we can get that planned out. Recordings of this Lunch and Learn and all others can be found on our Iowa Public Health Association YouTube channel, as well as any other past webinars that you may have missed or just want to revisit. But thank you again. Thanks, Tinika. Thanks, Katie. Thanks, everybody who joined us. Hope you all have a great afternoon.
Thank
We'll
you.
see
Have
you
a great
in
afternoon.
September.
Bye-bye.